Ismail Jatoi is with us. We're talking about breast cancer because he is here as an eminent expert in the area from America at the University of Texas Health Sciences Center in San Antonio in Texas. That sounds pretty impressive. Professor, nice to speak to you.
Thank you, Shaun.
You're over for the Breast Cancer Ball. You will be the special guest tonight at the Breast Cancer Ball in Letterkenny. And we spoke to Mr. Sugrue recently, who told us about you coming, and that's why we were keen to speak to you. And he tells us you've a big link with the hospital here and the work that's happening in the area of breast cancer.
Well, so Mr. Sugrue invited me to come, and we gave presentations yesterday to the community. I think there were about 60 some people there. And this morning there have been lectures from or talks from medical students and registrars, and I've attended those. And we've also had discussions. So, I mean, there's a huge volume, obviously, of breast cases and breast-related diseases here in Letterkenny at the hospital. And I think one of the things that I would like to comment on is, it's sort of surprising they have just one breast surgeon. I mean, I would think there'd be enough volume here for a second one, because they certainly do see a huge volume here in Letterkenny. And I've actually been very impressed by the quality and by the care that Mr. Sugrue and his team give patients, and I think it's a very, very well-run clinic.
You're surprised by the amount of work for one breast cancer surgeon. If this were America, wouldn't be the case, I presume.
Yeah, I think we would have two surgeons, I think, for volume this size. I mean, I think we would have two.
There's a perception, probably certain people have, that you get better treatment in America, that if you have cancer it's a better place to be and all of that. But I know people who've been to America treatment and said, actually, the surgeon said, who'd had treatment here, what you had in Ireland was fantastic in terms of treatment. What's your own view in the time that you've been here of the way people are treated with the cancer experience here?
Well, I think the care here is excellent. I think it's superb care, and I think so I think you have to understand, in the United States we have a huge variety of hospitals and clinics and so forth. We have specialist centers and centers that are less special. The care here, I think, is superb. I mean, the amount of time I've spent here and my interactions with the doctors and staff here, I've been very, very impressed by the quality of care.
The story with breast cancer is much more about women surviving now and even being cured, whereas I suppose when you started out in your medical work, it was not quite as positive as that it was being bought, I suppose. Yeah,
so breast cancer death rates have dropped by about 25-26% since 1990 in the United States as well as in Ireland. So we've seen a decline in breast cancer mortality since, and this decline began in 1990. Now, if you look at the American statistics, and the American statistics parallel the statistics in Europe and Western Europe, mortality rates have been flat for about the 50 years prior to that. But in 1990, we saw this sudden decline in breast cancer mortality that is still continuing. I think it's largely driven in the United States by several factors. One is mammography screening, which was introduced in the 1980s in the U.S., and the second is better drug therapy. So we've introduced endocrine therapy, which targets patients who have estrogen receptor positive breast cancers. We've introduced Herceptin more recently, which targets patients with HER2 positive breast cancers. And of course, then there's been adjuvant chemotherapy. So I think it's a combination of factors. I think it's increased breast cancer awareness, it's mammography screening, and it's also better drug treatments. The story has been essentially the same over the last many years. I mean, we've had sentinel lymph node biopsies and more emphasis now on breast conservation.
Just explain that, because I was reading some of your research last night, and as much as I could take it in, a non-medic, but you were talking about that in terms of women preserving more of the breast rather than, taking the breast completely away. I mean, is that always a risky thing for a surgeon to determine?
No, so there are trials that have looked at breast conservation, breast preservation versus mastectomy. And if done properly, breast preservation is an equal alternative to mastectomy. So breast preservation with radiotherapy gives you the same outcome as mastectomy. So there are options in terms of the local therapy of breast cancer.
Why would the breast have been taken away in previous years? And in that thought process, would it have been best to take the whole area away?
Well, there are certain instances where you cannot preserve the breast.
Right.
And, if you go back many years ago, most patients presented with very large, locally advanced breast cancers. With increased breast cancer awareness, we've seen a downstaging of the disease, and so patients are presenting with smaller tumors. We've also introduced radiotherapy. This was many years ago. And radiotherapy can augment surgery. So lumpectomy, that is partial mastectomy, plus radiotherapy provides the same outcome as total mastectomy.
So just to, I suppose, put it into layman's terms, if because of the mammography now and you get a clearer view earlier, you see that the lump maybe is smaller, so maybe, I don't know, maybe whatever size it is, a pea size or whatever, and you take that out and then you apply radiotherapy to the area around it, is that it?
That's correct.
And is that on an area that you think there may be cancer, or just in case there is?
Well, oftentimes it's whole breast radiation that's given.
Right.
There have been trials now looking at targeted radiotherapy. In fact, the targeted radiotherapy trials show that the targeted effect is just as good as the whole breast radiation. So I think even in terms of the extent of radiotherapy is shifting as we understand the biology of breast cancer more. But that's correct. So you can augment the wider surgery, the bigger surgery, with smaller surgery and radiotherapy. And that's been the trend, not only here in Europe but the United States.
And then a continuation of drugs afterwards.
That's correct. So adjuvant therapy. So what we realized is that and we talked about this last night at the community forum. So breast cancer has two modes of spread. There's obviously the lymphatics and there's the bloodstream. So the local therapy, the surgery and the radiation targets the local spread of the disease, which is lymphatics and within the breast. And then the systemic therapy, the drug therapy, targets the blood-borne spread of the disease. We've got some very effective drugs now that have had a very dramatic effect in lowering the burden of mortality in breast cancer.
Now, the Donegal Clinical and Research Academy are the people who were obviously presenting you with all of these papers and talking about the research that's going on. And it's quite exciting here, isn't it, locally as well, in terms of what's happening?
It is. My understanding is you have a very close affiliation also with the National University of Ireland in Galway.
Yeah.
And certainly I think that's enhanced the quality of care and the academic enterprise here in Letterkenny.
Yeah, and there are things being learned here, I suppose, that are then advancing other countries' techniques.
Absolutely, that's correct.
Yeah. What comes to mind in terms of Donegal?
Well, I think, and Mr. Sugar and I were talking about that. One of the things I think that's still evident here in Donegal, and we have the same issue in San Antonio, our communities in that sense are very similar. We probably see more locally advanced breast cancers here and in San Antonio. We do maybe in other parts of the world, for various reasons. But I think, understanding that and the potential effect that early detection mammography can have in improving outcomes, I think is important. And
do we need to look at why there are these locally advanced?
Well, I think it part of it may just be lack of awareness.
Right.
And so I think increased breast cancer awareness.
Breast check was rolled out very late here compared to other areas of the country as well.
That's correct. So I think that's true in San Antonio also. A lot of this has to do with breast cancer awareness. And an increased breast cancer awareness, I think, will result in better outcomes.
And it's always good when we have somebody like you on to just advise and commend to, and it is mainly women, some men, but mainly women, of course, that have this problem, what they should be looking out for.
Well, so if there's a lump, obviously they should go in for an examination. And now, lump is not always cancer, and in the majority of instances, in younger women, it's not going to be cancer. But it needs to be evaluated and ruled out. But breast cancer doesn't always present as a lump. I mean, it can also present as erythema or redness. We see that in inflammatory disease, inflammatory breast cancer. It can sometimes present as excoriation of the skin around the nipple areolar complex, what we call a Paget's disease. So there are different presentations. But I think understanding that, and then, of course, going in for evaluation is an important first step in terms of potentially reducing the burden of the disease and improving outcomes.
It's obvious that the most important thing that you've learned since 1990 before that is that women are checked early. And, that there is a kind of a call-up system for women of a particular age and those in the high-risk categories, like, for instance, if your mother had breast cancer or whatever, that you're seen early.
That's right. So I think breast cancer awareness, I think screening are important ways of reducing breast cancer mortality. You talk about family history. So, we're learning more and more about the relationship between breast cancer and hereditary. So, we now think that about 10% of all breast cancers have a hereditary base, about 10%. 90% are sporadic, 10% are passed down as germline mutations. And of the 10% that are hereditary, there are two genes that are the most common. They make up about half that 10%. That's the BRCA1 and BRCA2 gene. And, of course, that's gotten a lot of publicity in the States because of the Angelina Jolie issue, where she underwent testing and underwent preventive surgery.
Just stay with us, because I think it's interesting and important just to further develop that. And we will just after we've taken a break, because we've got the news headlines coming up, and Professor Ismail Jatoi is staying with us. He's the Chief of the Division of Surgical Oncology at the University of Texas Health Sciences Center in Texas, and he's been here to meet with the Donegal Clinical and Research Academy, who are doing superb work through Letterkenny Hospital, Mr. Sugru and all the great clinical team there. And he's going to be at the Breast Cancer Ball tonight, as well as a special guest. Let's go to the news headlines. Joining us with the latest, it's Greg Hughes. And those involved in the Donegal Clinical and Research Academy, which is it's a big deal, actually, in the area of breast cancer, isn't it? Is it all breast cancer, or are you talking about other areas of cancer here in this as well?
Well, my presentations today today and yesterday focused on breast cancer.
You have a fascinating history, by the way, because I was reading about the medals you've had, because you've been working in the American military as a surgeon for many years as well, and you've got gold medals and bronze medals. So the way it works there is if you're in the services, you have as good a service like an NHS, don't you?
Yeah, so the military service in the United States, the medical service, takes care of not only the soldiers but also retired military and their families, their dependents, and so it's a pretty large catchment population that we deal with. I think it's about 9 million, and the military hospitals are situated all across the United States. Some of them are large tertiary centers.
So just to go back to this two genes. In 10% of the cases of breast cancer, there's this, and 50% of the 10%, you say, that are gene-related. Is that right?
No. So 10% of all breast cancers are hereditary.
Hereditary. And
90% are sporadic.
Right.
Of the 10% that are hereditary, there are two genes that make up about half that 10%. Yeah. That's the BRCA1 and BRCA2. Okay.
So that's very helpful now, isn't it, in terms of helping people, because if you determine that they have these genes, then there's preventable surgery.
Right. So, well, I think it's important to emphasize there are three options that patients who carry the mutation have. One of them is screening, and we oftentimes recommend MRI screening for those patients. It's more sensitive, picks up more cancers. The second option is there's actually drugs that you can prescribe to lower risk. Now, these drugs cut the risk in half.
Are they available in Ireland?
Yeah, they're available in Ireland.
Right.
I mean, it's tamoxifen. I mean,
right.
It cuts the risk in half. So you go from, but you go from an 85% lifetime risk down to about a 42% lifetime risk, which is very high still.
Still high, yeah.
So ultimately, most patients will opt for preventive surgery. And
even though it's dramatic.
Even though it's dramatic, because with surgery you appear to have the most dramatic effect in terms of reducing risk. So if you carry the BRCA1 or BRCA2 mutation, for example, you have about an 80 or 85% lifetime risk of getting breast cancer. You have about a 20 or 40% lifetime risk of developing ovarian cancer.
Why, I mean, this might sound like a daft question, but I'll ask it anyway. Why does the cancer develop in the breast rather than somewhere else?
Well, that's a good question. I'm not sure if anybody really understands this. So the BRCA gene, we all have it. It's a DNA repair gene, and so it repairs damage to DNA. But besides the BRCA1, BRCA2, there are other mutations. For example, there's a P10 mutation, which is Cowden's disease, where you have breast and thyroid cancer. There's a P53 mutation, which is the Li-Fraumeni syndrome. I'm just throwing these terms out. But that mutation is linked with breast cancer, bone tumors, brain tumors. So it's interesting that these different gene mutations are linked to different cancers. And I think the entire reason for that is not fully understood and still under investigation.
And once that's understood, we'll be really getting somewhere, I presume.
Yeah, but I think we already have a pretty good handle already as to where these mutations have an effect in terms of cancer risk. And we've already begun, and certainly we're seeing more and more patients come forward for genetic testing and for intervention to reduce their risk based on these genetic tests.
So this repair gene, DNA repair gene, it's switched off, is it?
No, it's there's an alteration.
Right.
And so the alteration basically results in an ineffective way of repairing the damage from low-dose radiation.
So are these cancers happening anyway? And these genes are switching it off. Is that what's happening? If it wasn't?
Well, I think we're. This is a lot of this is going to be conjecture, but we're probably barraged with things around us that cause
toxins and
cause DNA damage. Then we have a mechanism in place to repair that damage.
Right.
And if you have a mutation in that gene, you're not able to repair the damage, and then you're susceptible to developing cancer. And so these patients have, as I said, for example, the BRCA1, BRCA2 gene have about an 85% lifetime risk of developing breast cancer and about a 20-40% lifetime risk of developing ovarian cancer. And the ovarian cancer, by the way, is really more lethal than the breast cancer.
Okay. And the new science now, the new sort of treatments, are they like inventing sort of genes to go in there or whatever to try and take on these cancers, if you like? I mean, what way is the future in terms of dealing with this?
Well, I think the future in terms of drug therapy is going to be more targeted therapy.
Right.
So chemotherapy is really non-targeted in the sense that it kills all cells. The more rapidly dividing cells, which are the cancer cells, are killed preferentially. But targeted therapy is where you target treatments against specific cells. So, for example, in estrogen receptor positive breast cancer, we have targeted therapy. We can give drugs that target the estrogen receptor, for example, tamoxifen.
Yeah.
Or we can give a drug that lowers the estrogen levels, such as the aromatase inhibitor.
Which feeds it.
Right, which feeds it. And in HER2 positive breast cancer, which is, again, a marker on tumor cells, we can now give Herceptin, which targets the HER2 positive breast cancer. So about 20-30% of breast cancers are HER2 positive, about 75% are ER positive. So we have targeted therapies for those types of cancers.
And why are there certain cancers that we just can't really get help with? Because there are cancers now like breast cancer, prostate cancer, that, we can get treatments for. If we get it early, most people can be saved. Why are there certain cancers that we just don't seem to have a handle on?
I think a lot of this has to do with clinical trials. So, the only way you really know if a treatment is going to be effective is through a randomized, what we call a randomized prospective trial. There are certain cancers where it's very hard to do randomized trials because there just aren't many of those types of patients. So breast cancer is very common, prostate cancer is very common, and we can do clinical trials quite easily in breast cancer and prostate cancer.
Because there's more people.
Because there are more patients.
And there's more money. And is it because there's more money in the pharmaceutical tests and everything else?
Right. And plus, to do clinical trials, you need a certain number of patients in a trial.
Yeah.
And it's easy to accrue those numbers, that sample size, in cancers like breast, but in rare tumors, it's not so easy.
There's great work going on here, you say, in Letterkenny and in Donegal, and there's great work going on where you are now. There's lots of good people, and great people in Northern Ireland as well, and we've had great advances too and elsewhere in Ireland. great advances in cancer research, but is it all pooled, or are there people for their own, like, selfish interest, because they're businesses, involved in development of drugs, that keep information for obvious reasons? They want to, develop the drug, and then they have the money if it's effective, that keep that information themselves. Is that always something you're conscious of?
No, I think it's increasingly getting, if you want to use the term pool, I think there's a larger and larger number of collaborations across the globe. Now, it's interesting. We have the largest breast cancer meeting every year in San Antonio, and it draws about 8,000 people. And I know there are doctors from Letterkenny who attend the meeting as well. And so it has a huge draw. And we present or topics are presented from across the globe. So, for example, this year, there are going to be trials presented from India and Turkey, at the meeting. So I think increasingly we're seeing people collaborate and provide information. And I think that's good, and I think that's going to be the future in terms of reducing the burden of the disease.
Will we have a cure for cancer one day, as in cancer per se? Well,
I hope so. Okay, but it may not be one cure. It may be multiple treatments for multiple different types of cancer. I'm not sure if it's just all one disease. I mean, I think we may be dealing with many different diseases. Even within what we call breast cancer, there might be different types of breast cancer and different diseases that we're really talking about.
So
we're clumping against breast cancer.
Our thinking has changed, really, because we saw cancer as a disease, and I know it affected different areas of the body.
That's right.
But people said one day we'll have a cure for cancer. You don't really say that now, then, because it's like saying, well, one day we'll have a cure for...
Well, I think we're realizing that cancer is very heterogeneous. Even within, as I said before, even within breast cancer, I mean, and my interest has largely been breast cancer, we see a lot of heterogeneity, and what we may really be talking about is not one disease, not one type of breast cancer, but multiple different types of breast cancer.
And that alters the way you approach it then.
That's correct. And so your answer to the question, will there be a cure? We all hope so. That's our goal. But it may not just be one singular cure. It may be multiple different cures for the different types of diseases that we call cancer that are out there.
It's fascinating, and appreciate your time. Thanks for joining us.
Thank you very much, Shaun. Thank you.
Professor Ismail Jatoi, Chief of the Division of Surgical Oncology at the University of Texas Health Sciences Center in San Antonio in Texas. And he's in Donegal for the Breast Cancer Ball this evening as well, and we wish everybody well that's attending that. It's going to be a big night, and obviously they do great work in the county, so good luck to Mr. Sugu and all the team.